Assalamu alaikum. Good afternoon. It's my pleasure to introduce my co-chairman, Dr. Jig Song. He's with me chairing the afternoon session. And I'm Dr. Hassan from Bahrain. We are soon starting our afternoon session, which is about respiratory failure with distinguished speaker. Our first speaker, it's my pleasure to introduce our first speaker. He's Professor Manu Marbrain. He's, I think, known, a co-founder of Fluid Academy, and he's now, he was director of many ICUs in Belgium, and he's currently leading the research in University of Lublin in Poland, and position of medical data management. He has a lot of interesting papers in fluids and abdominal compartment syndrome. Professor Manu will going to talk about mechanical ventilation in a patient with abdominal hypertension. Welcome, Doctor.
Thank you, dear Chairman, ladies and gentlemen. It's a great honor and a pleasure to be here in the beautiful city of Kuwait for the 20th Pan-Arab Critical Care Medicine Society conference. I will try to explain you how we need to set the ventilator in patients with intra-abdominal hypertension. It seems that the slides, I need to move them with this. No. Okay, here we go. So I'm an internal medicine physician, intensivist, and I got an interest in intra-abdominal hypertension over more than 30 years ago. Oh, I don't know. These are my conflicts of interest. And it looks like the slides are coming and going. Okay. Today will be about breaking some bad habits. It's not changing here. I do this. This one and this I don't use. But can you put this computer? No, it's changing here, but not on the screen there. Everybody lies again. Yeah, here it's working, but not there. It's okay. Now we're in business. Okay. After a brief introduction, I will tell you everything about the impact of abdominal hypertension on ventilator-induced lung injury, lung distension, recruitment, pulmonary edema, and the lymphatics. I will then present you a practical approach to be used at the bedside and will wrap things up. So to summarize my lecture, I would like to say that when abdominal pressure is increased and pushes the diaphragm upwards, this is a bit, I don't know why the screen is always going away, but if we set the PEEP to counteract the increased intra-abdominal pressure, we may keep the lungs open at the end of expiration. And this is illustrated by this video, but I'm not sure whether it will be playing. Let's try. No, the video is not playing. On the left, you see a normal abdominal pressure, and on the right, you see abdominal hypertension with an upward shift and dorsobasal atelectasis in this patient with muscle relaxants. So moving on to the respiratory effects of abdominal hypertension, I have to thank my good friend Paolo, who passed away, but with him almost 20 years ago, we wrote the first review on how intra-abdominal pressure affects respiratory mechanics. And later on, we developed this idea, and we were looking at organ. Now, this is not really working. Okay. I don't know why the signal is always moving away. Should I need to do something different?
Please.
Okay. So we will try to change some bad habits when it comes to AV logistics. No, this is just true. This is not fair. I haven't said that. So, but we skipped the introduction. I'll tell you the impact of hypertension on respiratory function and dynamics, and then something at the bedside. So to summarize my talk, I could just leave you the room saying that PEEP should be set to counteract the increased intra-abdominal pressure after recruitment of the lungs. Video is still not playing, but doesn't matter. I thank my good friend Paolo. With him 20 years ago, we wrote the first review on how intra-abdominal hypertension affects respiratory mechanics, looking at organ-organ interactions. As said, I'm an internal medicine physician, and I like the impact of increased abdominal pressure on all organs, not only within the abdomen, but far outside. And the respiratory effects are just listed there. I'm not going into detail, but it's very important to measure the pressure in order to set the ventilator right. Let me illustrate this with a case of a patient with abdominal sepsis. You can see there is ascites, there is distension of the cecum, and there is some free air in the wall there. There's something fishy going on. Abdominal pressure was 26, CVP was 20, so barometric filling pressures will be increased and the patient is in multi-organ failure. A typical chest X-ray, if the abdomen is distended, is that the diaphragm is pushed upwards. We call this the baby lungs, and intrathoracic pressures will be increased so that transmural pressures are altered. In the patient on CT, we see that there are ventilated, recruitable, and collapsed areas in the lung. And after intubation and PEEP setting, you can see that the PEEP now pushes back downwards the diaphragm after recruiting the lung. In this patient with abdominal sepsis, things got worse over the next days, and you can see that we have 2 wide lungs, secondary ARDS, with very poor oxygenation and increased lung water. So we here have an extrapulmonary problem that is causing the ARDS because there is an abdominal problem, the abdominal sepsis in this patient. So we probably need another mindset to open the lungs and keep the lungs open. This is another video. Okay, this is playing. We see a burn patient, distended abdomen. Tidal volume is 130 ml. It's an old case, but you can see peak pressures of 55 centimeters of mercury. Small tidal volumes, high peak pressures, and then cardiac arrest. Intra-abdominal hypertension is a killer. And what we saw is a patient with fluid overload, hypothermia, abdominal distension, high peak pressures, 55, as a surrogate for increased abdominal pressure, low tidal volume, and cardiovascular collapse. So I would like to ask within the audience who measures intra-abdominal pressure. Could you raise your hand? Okay, I see there. So I would say it's 17.8% of the audience, which is okay, but I think we could do better. And nowadays, we have modern technology available to monitor abdominal pressure continuously. As, for instance, this trauma guard balloon is a Foley catheter with 3 balloons. Tension balloon and 2 balloons at the tip, 1 air-filled balloon to measure the pressure and 1 water-filled balloon to protect. And this is connected via smart cable to any bedside monitor. We were able to test this in vitro with good results. And now we have a monitoring tool on the left you see to monitor continuously. And with some algorithm and calculation, we then identify the pressure time burden, similarly to increased intracranial hypertension. Later on, we tested in pigs and in human cadaver. Also there, correlation, Blunt-Altman bias precision were good. And the results of the first in-human study will be presented at SCCM, where we follow 25 ICU patients, and you can see at different head-of-bed positions, the correlation with the Foley manometer was good. So continuous intra-abdominal pressure monitoring may be the way forward to go. And one of the reasons is that now you can track continuous tracing of the pressure, and you can see immediately the effect of your treatment. This is a continuous abdominal pressure tracing. On the bottom and on the top you see end-tidal CO2. So when the patient is fighting with the ventilator, contracting his abdominal muscles, abdominal pressure is increased, and at the same time we see that end-tidal CO2 increases. By giving neuromuscular blockers, you see that both parameters get back to normal. So now a little bit of boring part on the theoretical concepts behind. And the respiratory effects can be divided into villi, the lung distension, recruitment, lymphatics, and presence or induction of pulmonary edema. So let's first start the relation between abdominal hypertension and villi. Comes from animal experiments where it was shown that abdominal compartment syndrome increases cytokines like IL-6, IL-1 beta. What about lung distension? Lung distension can be determined by the balance between the ventilatory capacity and the ventilatory load, or the imbalance. And if we look at the ventilatory load, chest wall compliance plays an important role. Chest wall compliance is altered, for instance, in patients with obesity, with ascites, with edema of the bowel wall, and of course also in patients with intra-abdominal hypertension. If we look in this study, patients with sepsis follow-up on admission, in the middle you can see before decompressive laparotomy, so the abdomen, which is normally ellipse in size, becomes more like a sphere, so there is more tension, and after decompressive laparotomy you have the release, and this affected lung volumes. You can see that when abdominal pressure gets back to normal, there is an increase in total lung volume and a higher percentage of I-rated recruited lung volumes. Now, if we follow our typical ICU patient at baseline, if we would put then an abdominal Velcro belt to prevent incisional hernia, and then adapt the PEEP according to the intra-abdominal pressure, remove the belt and go back to baseline. Let's see what's happened with intra-abdominal pressure. Putting the belt and the PEEP will increase intra-abdominal pressure. And this will also increase alveolar pressures. Pleural pressure goes up, and pulmonary artery pressure also goes up. And this is like you saw in the case with the very high peak pressures. On oxygenation, we see the opposite. We have a desaturation with abdominal hypertension, and after recruiting and setting the PEEP equal to the abdominal pressure, we can even have a more important benefit on PO2. So it's like a recruitment maneuver. Compliance, dynamic compliance also drops with abdominal hypertension. Now I would like to thank my other friend Luciano, because Luciano was the senior author of my two first publications on the incidence and prevalence of abdominal hypertension, which founded my PhD thesis about 20 years ago. So I thank Luciano for being a friend and a mentor. He did seminal studies looking at the impact of abdominal hypertension on chest wall elastance. And the fraction between the chest wall and the lung may be changed in situations of abdominal hypertension. And they found that there is a relation between abdominal pressure and the chest wall elastance. So the higher the pressure, the higher the elastance, or the lower the compliance. And you can see here when separating pulmonary in blue and extrapulmonary in black, the extrapulmonary patients, like the one I showed you, have higher abdominal pressures. In another study, they also found a relation between abdominal pressure, especially in obese patients. They have higher pressures, but also in the surgical ARDS, read the extrapulmonary ARDS, read the ones with abdominal hypertension. So that's why Luciano and co-authors proposed to talk about pulmonary and extrapulmonary ARDS as different syndromes that need to be treated differently. So now let's go back to some pig studies, also from the group of Gattinoni and Michael Quintal, where they induced ARDS with oleic acid, and then they also increased intra-abdominal pressure. you can see that chest wall compliance is altered, but if you look at the lung are not altered by abdominal hypertension. It's the chest wall that is becoming stiffer. In a study in rats, it was also found that there is a good correlation between abdominal pressure and the lower inflection point to set your best and optimal PEEP. And the higher the abdominal pressure is a right downward shift, alluding to a poor compliance. We did some preliminary studies in humans where we found that there is a rightward shift of the total respiratory system PV curve, and the problem was in fact laying in the chest wall by measuring pleural pressures. We found a good correlation between abdominal pressure and the lower inflection point, especially in secondary ARDS and less in primary ARDS. So what's the impact on recruitment? Imagine you have a patient with a sticky atelectasis that requires a transpulmonary opening pressure of 30 centimeters of water. If we apply a pressure of 40, we would assume that we have opened the sticky atelectasis, taken into account a normal abdominal pressure and a normal relation between lung and chest wall elastance. So with a pressure of 40, the transpulmonary pressure would be around 34 and the lung will be opened. But now imagine the same patient with an increased intra-abdominal pressure where the relation between lung and chest wall is different. The transpulmonary pressure will only be 20 and we will not have recruited the lung. Why? Because recruitment is a continuous ongoing process, and if abdominal pressure is increased, the curve shifts to the right, so we need higher opening pressures. In the deflation limb, if abdominal pressure is increased, we will also see that the closing pressures are shifted to the right, so we need a higher PEEP to prevent the lung to collapse. Reason being that there is a relation between abdominal pressure and pleural pressure. So in a recent paper written with Paolo Pelosi, we kind of summarize the ventilator settings at the bedside. So what about lung edema? Is another pig study from the group of Gattinoni-Pelosi, where they induced ARDS with oleic acid. And you can see when abdominal pressure is normal, the lungs are flooded with fluids at 0 alveolar pressure. And then if you increase the pressure, recruit the lung, you can squeeze the fluids out of the pigs. If abdominal pressure is increased, you see the upward shift of the diaphragm, and you see for the same pressure, you have not recruited because transpulmonary pressure is not 40, but maybe only 20 or below. And they found in their study in normal abdominal pressure that the dorsobasal regions of the lungs are wet and flooded, but if you increase abdominal pressure, it's kind of you flood the lung from the base to the top. And this will result in an increase in extravascular lung water. So the final point is the lymphatics. And we know that fluids from the lungs can be drained transpleurally via the hilus or transabdominally with the ductus thoracicus. And here I would like to thank my good friend Goran, who passed away, and also with him, almost 20 years ago, we published this review on how the lymphatics are important to keep the lungs dry, and especially in patients with intra-abdominal pressure. Because when there is sepsis and fluid resuscitation, abdominal pressure may increase. This will initially increase lymphatic flow to a certain limitation of an abdominal pressure around 20 centimeters of water. When flow will decrease, interstitial fluids will accumulate, further increasing abdominal pressure and further decreasing lymphatic flow, triggering a kind of a vicious cycle that may lead to abdominal compartment syndrome. So we have the 5 major effects on respiratory dynamics of intra-abdominal hypertension. So the question now is, how do we translate this to the bedside? I told you already we should set the PEEP to counteract the intra-abdominal pressure, And everything you need to know is available in this open access paper on how to set the ventilator. Some of you may wonder, if I increase the PEEP, this will further increase intra-abdominal pressure. But in a study we performed, we saw that there is only a marginal increase in intra-abdominal pressure. If abdominal pressure is 10 and you put a PEEP of 10, the net effect will be 0. So on average, if the PEEP is set at 15, the intra-abdominal pressure will increase with about 1.5 millimeters of mercury. You have the conversion 1.35 from centimeters to millimeters of mercury. So the question is, if intra-abdominal hypertension increases the lower inflection point, how then should we set the PEEP? I showed you the animal data in rats, and the question is, what can we do in humans? This is just a screenshot from the Evita, where we compress the abdomen with a belt. So at baseline, pressure is 12. With the belt, the pressure increases to 24. And you see exactly like in the video that the tidal volume is coming down, compliance is coming down. So it makes sense, taking into account the abdominal thoracic index of transmission, to set the PEEP in accordance to the intra-abdominal pressure. So let's dive a little bit deeper in this, going back to some pig studies to understand whether it's a good approach. This was abdominal hypertension with a balloon in pigs, but the PEEP was not much equal to the intra-abdominal pressure. So PEEP below intra-abdominal pressure cannot prevent the decline in FRC. Then there was another study by Luciano Azevedo where they matched the PEEP. You can see there that without injury, with hypertension, with injury, and with both, you see a rightward, downward shift of the PV curves. And they saw that when you match the PEEP equal to the intra-abdominal pressure, you see that there is an improvement in so with abdominal hypertension, there is an increase in the inflection point, and then setting the PEEP, you can see that compliance gets better and the difference between alveolus and arterial oxygen is also getting better. There was another pig study, equal the PEEP to abdominal pressure, and they resulted on top in better end-expiratory lung volumes, better PF ratio, lower shunt fraction, and lower dead space. And there was one human study in a small sample where it was found that extravascular lung water was lower in the patients treated with PEEP set to the intra-abdominal pressure. The common denominator of these studies is that increasing the PEEP to the intra-abdominal pressure may result in hemodynamic compromise. So just one very last more thing. You may ask yourself, why am I showing an elephant in Kuwait? But if you reduce chest wall compliance by putting a weight on the chest, you may have an improvement in gas exchange. So putting a weight, e.g. for 10 kilos on the chest, may improve oxygenation. And this was a study in 11 patients where there were 8 responders, and this resulted in better oxygenation. This is what we do at the bedside. We don't do it when the family is there because they're gonna ask a lot of questions. But it makes sense. Why does it make sense? If you put a weight on the chest, you decrease chest wall compliance. You could also think of putting a shell to get a negative pressure on the abdomen. So you decrease chest wall compliance, you increase abdominal compliance, you get dorsobasal recruitment. And if you look at prone positioning with the abdomen hanging free and you turn the patient upside down, the weight plus a vacuum will have the same effect and maybe less cumbersome for patients. So to wrap things up, I hope I convinced you the importance of abdominal pressure, and you need to know it in order to set the ventilator right. Think about setting the PEEP equal to the abdominal pressure. Of course, with a maximum of 20, maybe then you need to look for a surgeon to do something else. And as take-home messages, measure the pressure. If you can, also esophageal pressure, cardiac output monitoring. Think about polycompartment syndrome, interactions between the abdomen and the chest. Avoid head of bed positions if the patient is obese, high body mass index, and abdominal hypertension. You can calculate the abdominal thoracic index of transmission. We need to use higher opening pressures to recruit the lungs. So not 40 by 40, but maybe 40 plus half the abdominal pressure or something. Measure the extravascular lung water as there is an exponential increase. Use higher PEEP settings, and as a rule of thumb, just set the PEEP in centimeters of water equal to the abdominal pressure in millimeters of mercury. And this will take into account the index of transmission of about 50%. You can try deep sedation and a short course of neuromuscular blockers. Think about body positioning and use a lung protective ventilation strategy. Thank you for your attention.
Thank you, Dr. Malbrain, for your insightful presentation. We'll save the questions to the end. Our next speaker is Dr. Pratik Sinha from the United States of America. Dr. Sinha is a trained physician scientist in the intensive care and emergency medicine with a clinical experience spanning 3 continents. He currently attends at the ICU at Washington University in St. Louis, where he leads cutting-edge research, including ventilator ratio, which we heard yesterday. Dr. Sinha?
Great. Thank you very much. Excited to talk about measuring and mitigating spontaneous ventilation during mechanical ventilation. I've added 3 words about friend, foe, and frenemy because I have some conflicting relationship with the idea of spontaneous ventilation, and I hope to talk about this. Some things to clarify. You can think of me as the hype man for Professor Slutsky, who's going to follow me, who's really the world expert when it comes to thinking about P-Silly. And also, I wish I could have borrowed Professor Malbrain's slide of all those people sleeping, because this is going to be all concepts of respiratory physiology. Okie dokie, so these are my disclosures, none of which are relevant to the talk that I'm about to give. The overview of what I'm going to talk about, I'm going to, for those of you who've been to any of my previous talks here, I've been bad-mouthing ARDS and its definition, so I'm going to sort of carry on that theme. I'm going to run through a few important concepts about ventilator-induced lung injury, and some of these concepts we need to carry forward both for the purposes of my talk and the following talk afterwards. And then talk about spontaneous breathing. We know spontaneous breathing is good, and we know negative pressure breathing is good because we're all doing it right now. And so why is it potentially problematic in the context of an acutely injured lung? And how do these problems manifest themselves? How can we think about this problem? How can we pick it up at the bedside? And also, how can we quantify the potential problem that this might cause to our patients? And then how can we mitigate this? And this is the bit where the concept of the frenemy comes in, because unfortunately for us and our patients, none of our interventions in the ICU come for free. They all come at a cost. So the real question is that is this a big enough problem for us to think about introducing some of these really costly interventions? So let's talk about how we diagnose ARDS. You can see this is the Berlin definition, and as this talk is mostly based around invasively ventilated patients, the Berlin definition is still probably relevant. You can see we diagnose people based on their x-rays, based on the PF ratio, and how much PEEP they're on. What isn't here is the fact that there is no association between disease. We know nothing about what's driving this, and actually inflammation may be an important component of this when we think about how we manage our patients and how we sort of weigh up the cost balance of the interventions that we propose. And this is my big bugbear. There is absolutely no indication in the definition of how we diagnose people with ARDS about respiratory mechanics. Now, when I hear about a new patient coming into our intensive care and I hear that they have a problem with oxygenation, I'm interested, I'm a little bit worried, but when I hear that there is a problem with ventilation and they have low compliance, that's when I get really concerned. And when we're looking after our patients at the bedside, we know the deal is different for failure of oxygenation versus failure of oxygenation and ventilation. So I think these are important information that we need to carry forward with us. And another piece of how we actually operate as clinicians is that what's more interesting is the functional or dynamic components of respiratory mechanics. And again, that is something that I hope to show to you is quite important. And then finally, where we are in our phase of lung injury. And the story is very different in the acute setting. And we know that the trajectory of how patients show up initially with a lung injury and then how they shift into different phases really dictates how we think about all of these respiratory physiology concepts. So the first concept that I'm going to talk to you about, and Professor Malbrain touched upon this, was the baby lung. This is a very elegant and simplistic, but a very pertinent demonstration and a conceptual framework of what happens in acutely, severely injured lungs. Represented here, unfortunately, it looks better on my screen, is that you have some areas that are darker on the CT scan. And what this means is as the lung gets more injured, the amount of aerated lung becomes smaller. Now, this is important because like any other physical system, the way pressure sort of disseminates and dissipates when applied to a system is it takes the path of least resistance. And when you have certain segments of the lung that is more compliant than others, the pressure gets dissipated into the more compliant part of the lungs. So when you're delivering lung protective ventilation, or at least what you think it is, through low tidal volume, it is important to acknowledge that in the context of the baby lungs, even low tidal volumes can sometimes be injurious. So it means we need more information. Another important thing about the baby lung, again, as touched upon previously, is that it is definitely gravity dependent. In this study by Pelosi and colleagues, you can see that the gas to tissue ratio on the y-axis, first of all, that curve is very different in normal healthy lungs compared to ARDS, but as you go from front to back, the amount of aerated lung becomes smaller and smaller, again demonstrating the pictorial and physiological concept of the baby lung. It's also important to understand that lung inhomogeneity, i.e. the heterogeneity of alveolar units, what they're collapsed, what their compliance is different as you go from the front to the bottom. And this inhomogeneity has consequences. In this sort of very elegant series of studies by Kari Perlman and Jahar Bhattacharya, I was fortunate enough to work in Professor Bhattacharya's lab. In the top pictures that you see are normal alveolar units. The bars represent the maximum distension of the alveolus. In the bottom two images, what you see is the flooded alveolus next to a normal alveolus. And then you can see the same pressures applied have different consequences. Firstly, the alveolar flooded, which is the green alveolus that you see over there, you can see the distension is smaller. However, the adjoining alveolus shows that the distension is much higher. And work from Professor Slutsky and many others have shown that this inhomogeneity has consequences in terms of how much inflammatory signal is generated, and this can perpetuate acute lung injury. So what I want you to take forward is that the baby lungs are heterogeneous, they're gravity dependent, they're dynamic, and one of the challenges we have as clinicians is that the extent of the baby lung, or how big or small it is really quite difficult to estimate at the bedside. Okay, now we move on to the concept of lung stress and strain. Lung strain, just purely from viewed from a physical concept, is the ratio of the increasing length of a structure divided by its resting strain. So how much do you get stretched out from your resting state? Functional residual capacity in the lungs is the resting state, and the tidal volume that we deliver is how much you're moving away from it. And that is how we estimate what lung strain is. Now, the other concept that we need to take forward is that lung strain is not always equal. And actually, it's a dynamic process. And dynamic strain and cyclical strain are worse for us. Now, in these In this set of images, in the top row, you have conditions of high strain where the excursion is much higher from the baseline. And you can see from the initial to the final lung weight, after subjects have been exposed to this high strain condition, high dynamic strain condition, you can see that the lung weight is higher. However, when strain is higher, but dynamic strain is not high, you can see that the lung weight doesn't change between the initial and final points of measurement. Lung stress, which is what drives barotrauma, is the pressure applied to a respiratory system. And this is estimated by your transpulmonary pressure, which can be calculated from your alveolar pressure minus your pleural pressure. Now, at the bedside, we can estimate that quickly, but reasonably, using driving pressure. I don't think I need to introduce any of you to this landmark and excellent study by Amato and others, which show that as on the x-axis your driving pressure increases, your risk for death and mortality also increases as shown on the x-axis. So we know that how much you stretch and how much pressure is on the respiratory system are determinants of poor outcome, and that these are likely to be dynamic. So now I'm going to show you some important information that starts to introduce the idea of pleural pressure and also negative pleural pressure. And I've stolen these slides from Professor Slutsky and Marco Ranieri. At the top left here is the conditions under which we breathe normally. You can see at the bottom is your transpulmonary pressure, which is PTP. And you can see that the alveolar pressure here is 0, but we're generating a -8 pleural pressure. So we breathe in, and that drags atmospheric air into the lungs. And that's how we operate normally. Now, I'm going to take your attention to the figure most closest to me, which is one of my favorite figures, and it's of somebody playing a note on a trumpet. Extraordinary alveolar pressures here of 150, and you need to pay attention because this is blinking away, so please, it's going to stop you from sleeping. You can see alveolar pressures of 150, but it doesn't cause injuries because the pleural pressure is 140, and actually a transpulmonary pressure is 150. So what happens if you start spontaneously ventilating, generating negative pressure in the context of high alveolar pressure? And herein lies the rub of what I'm about to talk about. This is the condition of scenario E. In this cartoon, what you can see is that somebody on non-invasive ventilation is getting 10 centimeters of water. However, they're breathing quite hard because they're in respiratory failure, they're generating -15 of pleural pressure. The cumulative transpulmonary pressure here is 25. And this is potentially injurious and problematic. So I'm first going to go through scenarios about why spontaneous ventilation, by and large, is our friend. So there are several benefits of spontaneous ventilation during invasive mechanical ventilation. Principal among those, I would say, is that the only way to get off the ventilator is through spontaneous ventilation. I will sort of turn your attention back to the fact that we need to start thinking about these problems, not as static problems, but as problems through our patient's journey through critical illness. And in the weaning phase, when you're in the recovery phase from your lung injury, of course, we all lean on spontaneous ventilation. It's natural, it's how we breathe, and it can potentially be beneficial, particularly when we start thinking about diaphragmatic atrophy, which is a real problem with prolonged mechanical ventilation. It can improve your VQ matching and air rate dependent areas of lungs. It can also potentially be hemodynamically beneficial. It can improve venous return and therefore increase your cardiac output. And there are also theoretical benefits of improving your secretion. And we know that sort of long-distance runners who are sort of high-performing athletes have sustained high respiratory rate, high work of breathing over a prolonged period of time, and yet they don't get lung injury. So when does this high negative pressure scenario become a problem? Well, the idea is that there is a two-hit model. In the context of ongoing infection, inflammation, injury, when you then start introducing high transpulmonary pressures, this is when we potentially start running into trouble. And broadly speaking, the science that I'm talking to you about is called patient self-inflicted lung injury, or PSILI. And this is the proposed framework. You have your initial lung injury, and again, I apologize for the flashing of the...
You must step away and don't touch your laptop, just use the remote, because the HDMI gives...
Oh, it's unstable. Thank you, I appreciate that. Okay. I think the stepping away thing is definitely good. All right. I'm going to try and talk to you from a distance. So the conceptual framework of this is that you have the acutely injured lung, you get capillary leak, edema, which then sort of perpetuates the gas exchange problems, and that in turn changes your pH and other molecular factors, including inflammation. Thank you. It increases your metabolic changes, increases your respiratory drive, which in turn increases your pulmonary pressure, causes increased stress, increased strain, and then you get into this vicious cycle where, as a consequence of the patient taking breaths, they generate higher transpulmonary pressure, cause more edema, and it makes your lung injury worse. As Dr. Slutsky is here, make a small request that rather than call it patient self-inflicted lung injury, I would argue that once a patient hits the hospital and we're in charge, it's really the inability of us as caregivers to match their ventilatory demands that causes this problem, rather than the patients themselves. It's a small thing, but I think it's an important factor to realize that really this is a problem of not matching the patient's perceived ventilatory demands to what we're offering them in terms of ventilatory support. So in this cartoon, what I've tried to do is show you what the consequences are of negative pressure in the context of a stiff lung that's difficult to ventilate. Here we have our patient, which is they're on a mechanical ventilator. As you can see at the bottom, we have evidence of lung inhomogeneity and the baby lung. I've also introduced the diaphragm because another important concept is not just injury to the lung, but also myotrauma to the diaphragm. And as we go from back to front, we see increased ventilation preferentially and increased compliance. And as we go from front to back, we see increased inhomogeneity and increased perfusion. So what happens here as the diaphragm contracts, you're pulling the diaphragm away, and the consequences are that first, again, you have to remember this is all in the context of difficult to ventilate lungs, poor compliance. You get increased tidal volume, which increases your strain. You get increased transpulmonary pressure, which increases your stress. You can increase your transvenous pressure as a consequence of generating negative pressure in your intrathoracic compartment, which will increase your transvenous pressure and perpetuate the edema. So what's happening in the dependent regions of the lung? There is good animal data to suggest that when you try to breathe and generate negative pressure, it is this area that you increase aeration in. And I will turn your attention back to those images that I showed you from Carrie Perlman and colleagues, where in this area, the delta value of changing aeration and transpulmonary pressure has potentially got a much more profound impact in terms of perpetuating lung injury, because you have inhomogeneous alveolar units. So you can get breath stacking as a consequence of the diaphragm contracting, and it causes ventilator asynchrony, which has an impact on lung injury, but also on the diaphragm. And also the diaphragm, for reasons that I'm about to show you, won't contract in a way that's coordinated with the mechanical ventilation. And it's a phenomenon called eccentric contraction. And again, this can cause increased loading on the diaphragmatic muscles, working against the system that's trying to shove air in, and this can also lead to diaphragmatic atrophy. Now, the regulation of the respiratory drive is complex when we're breathing normally. However, in the injured lung, and particularly in patients with multi-organ failure, this becomes much more complex. And Spinelli and colleagues have proposed this rather elegant sort of conceptual framework of what happens in acutely injured lungs. On the x-axis, you've got PCO2, and on the y-axis, you've got your minute ventilation, which is the classic how much ventilation you're offering and what is your ventilatory efficiency. That curve moves up with ARDS and acute lung injury. But what also you get is a dissociation between what your respiratory mechanics believes to be the relationship of minute ventilation against PCO2 and what the brain thinks the respiratory drive in. And this potentially has a lot of problems, causes a lot of problems when we're trying to match ventilatory load with what the brain perceives to be the ventilatory demands. So how do we measure spontaneous ventilation or injurious spontaneous ventilation? With those people that are not mechanically ventilated, it's much simpler. You can look at things as chest expression, increased work of breathing, use of synostotic mastoid muscles, nasal flaring. All of these things we use all of the time, and they're an excellent measure of whether or not our patients are struggling, either on high flow, non-invasive ventilation, or otherwise. There are some scoring systems that are available. Another great marker is that if you see rising values of arterial PCO2, it suggests that we're not meeting the ventilatory demands. For those people who are mechanically ventilated, one option is to use esophageal manometry, and that helps us generate the transpulmonary pressure, and that's useful because it can also give you an idea about how much pressure you're generating and whether or not that's leading to increased stress. You can see from the blue deflections on the left here that there is increased inspiratory effort compared to the patient on the right, where there is low inspiratory effort. There's the idea of PMUS, which is quite complicated, but I want to just point your attention to the pressure time product, which is the area under the graph of the curves generated by esophageal pressure, and that's really the gold standard of how much respiratory drive there is. But the problem with the esophageal manometry is that it's not frequently used in most ICUs, and I have to say my own practice has changed since we started using more prone positioning, that I'm using it less and less, and unless you use it all of the time, these readings become infrequent. The P01 is a measure that's generated or estimated by the ventilator, and this is a very old metric that was described about even before I was born, actually, and it's measuring the change in pressure at the first 100 milliseconds immediately after the onset of inspiration. And because the respiratory mechanics haven't had a time to kick in, this is a good measure of your respiratory drive from the brain. In this chart, you can see in a rebreathing exercise amongst normal healthy adults, as the PCO2 goes up, your P102 goes up, and it correlates very well with what I showed you before, which was the pressure time product, which is probably in the absence of sort of tapping into the brain, the gold standard of what the respiratory drive is. I think I'm running out of time, so I'm going to rush through all of these. So this is the frenemy bit. What can we do to mitigate our approaches to improving drive pressure, improving respiratory drive and spontaneous breathing? Well, first of all, we can try and optimize PEEP, and again, I think Professor Slutsky is going to talk a little bit more about this, but the enemy here is that as you increase PEEP, you can potentially increase stress and cause more lung injury. You can increase the amount of ventilation that you're offering the patient, and this has issues with strain. And it just sort of started making me think about when is permissive hypocapnia or permissive hypoxia a problem, and what its implications are in patients who are harmed by spontaneous ventilation. You can minimize irritating exposure. Again, this is rare to find in the context of a well-managed patient. And then there's medication. There's studies to suggest that opiates might help, but this has consequences in terms of GI symptoms. You can increase sedation. The enemy here is Vasily, who has talked about why sedation is a problem amongst our patients. Neuromuscular blockade, it can lead to ICU weakness. So all of these interventions come at a cost. And then there is extracorporeal CO2 removal, and the enemy here, of course, is data. I'm going to skip through some of the other bits that I'm going to show you because of time, but really what I'm arguing is that these interventions may have failed because of a patient selection, both in terms of and CO2, extracorporeal CO2 removal, but also neuromuscular blockade. So, how do I think, so probably all of you are thinking, well, what does this all mean? So my takeaway from all of this is that we have a lot of information that we're leaving on the table when it comes to managing our patients. And the question I ask myself when we're thinking about precision medicine is how can we use some of these measurements about spontaneous ventilation and pressure changes to try and better manage our patients. And this is a helpful list compiled by Bertoni and colleagues, where these are the outputs that you can either get from esophageal manometry and or PO1 that tells you about the state of the lungs. And amongst these, I'm most excited by the dynamic measurements where can we start thinking about esophageal swing as a metric of how we decide subsequent interventions. So to summarize, spontaneous ventilation during invasive mechanical ventilation and otherwise may be a potential and a relevant source of lung injury. We have emerging diagnostics to monitor not just whether or not patients are spontaneously ventilating, but what its impact might be. But I would argue before we sort of implement this into our daily practice, that we try and establish what is the true scale of this problem and what is its impact. And that right now is unclear because there's a lack of human data. So I'd say this is not quite ready for prime time, but it's very much ready to escalate this to large-scale human studies. And then finally, I leave you with the thought of whether treatable traits might be, whether spontaneous breathing during low compliance might be a potential treatable trait. Okay, thank you for your attention.
Thank you very much. Thank you. Thank you for this fascinating talk. Our next speaker is Professor Artsluski. He's authority in ARDS and mechanical ventilation. I am proud to be one of his students during my fellowship, and he's going to talk about patients' self-inflicted lung injury in intubated and non-intubated patient. Welcome.
Thank you. Let me first start by thanking Pratik for setting this up very nicely. I'm going to be talking about patients' self-inflicted lung injury. First of all, conflicts of interest, I have none really related to this particular talk. So let me give you a brief overview. I'm going to give you a very brief review of mechanisms of ventilator-induced lung injury. Pratik talked about this somewhat. The real question I'm trying to address is patient's self-inflicted lung injury a real entity? And I'll explain why I think is important. Thank you. I'm going to review some animal data first, then review the human data. And the human data, quite frankly, is very indirect. And if you want to know the bottom line to my talk is we don't have enough human data to say this is a real entity, although I think it probably is. Talk a little about the mechanisms of injury. You've heard a lot about that, so I've cut down some of the slides. How do you recognize it and monitor it? Again, Pratik went over this. Clinical implications, and then conclusion. So in terms of ventilator-induced lung injury, we know that mechanical ventilation can cause lung injury by a number of mechanisms at a high level. One is at low lung volumes, something called adelic trauma. When the lung collapses and reopens, that can lead to injury. We also know that at the other end, at high lung volume, if the lung is overstretched during mechanical ventilation, that can also cause lung injury. That's increased stress and strain. The critical point about these two modes of injury is that really they don't depend on there being a mechanical ventilator. They don't depend on this being positive pressure. The same mechanisms can hold when breathing spontaneously. So in fact, really, the title here is ventilator-induced lung injury. In fact, we think, we've written this, that probably a better term is ventilation-induced lung injury, because these same mechanisms can hold whether you're breathing spontaneously or on a mechanical ventilator. So given that, that's when we came up with this concept, Laurent Bouchard and Antonio Picente and I, that maybe mechanical ventilation actually can treat disease by minimizing this self-inflicted lung injury. And you've seen the cycle before, Pratik went through it, but I think the important point here is that injury can lead to further injury because of spontaneous breathing. So spontaneous breathing via a number of mechanisms, and I'll talk about some of the mechanisms in a few minutes, can lead to injury. So the key question I asked is, is this real? And I think when we look at the animal data, I'm only going to show you a few studies, but I think from the animal data, it's very clear to me that P-silly can happen. Like mechanical, spontaneous breathing imposed injury can occur. So let me show you a couple studies. The first study was a very nice study published a long time ago now, 1988. Mascaroni and colleagues in Ted Colombo's lab showed this. They had the hypothesis that normocapnic hyperventilation might lead to lung injury. And what they did was they did a simple experiment. They had 3 groups. Group 1 was given sodium salicylate injected into cisterna magna. That increase in acid caused hyperventilation of the animals. And these spontaneously breathing animals, some were breathed on room air, and clearly when they're breathing on room air, they're going to get hypocapnia. So they had a group that also had higher inspired CO2 to maintain normocapnia. So that was the hyperventilation group. And then they had 2 controls. Control group B was given salicytate, the same dose, but was given a sedative and mechanical ventilation to stop the animals from breathing spontaneously. So to look at, is it the salicylate that's causing the problem? And the third group just received saline as well into the cisterna magna and room air and breathed spontaneously. So those are the 3 groups. What are the results? Well, they looked at oxygenation, they looked at a number of factors. This is the pathology. So there's 3 groups: salicylate, spontaneous breathing, that's group A, then group B, salicylate plus mechanical ventilation, then spontaneous breathing. And these were the pathology. This is how they described the results back then. If you look at the right, severe lesions, 56% of the animals given salicylate had severe lesions on pathology, 31% had mild lesions. And the other 2 control groups, the salicylate with mechanical ventilation and spontaneous breathing alone, 0 had mild lesions and 0 had severe lesions. So they all had normal lungs. It looked at AA gradients, AA differences. You can see here that the AA difference was much higher in group A, 431, versus about 225 or 250. So these animals had pathology that looked like ARDS, or acute lung injury. They had atelectasis, and that was just based on breathing spontaneously. So that was, I think, one of the first studies that suggested, yeah, maybe breathing spontaneously can lead to injury that looks like ARDS. I'm going to give you a couple of studies from Tasheki Yoshida. He's done some beautiful work in this area, I think some of the best work. In this particular study, they compared spontaneous breathing and then with muscle paralysis and 2 different severities of experimental lung injury. The hypothesis was that experimental lung injury that was minimal, might have less of a different effect than a greater injury. So they looked at rabbits with lung injury, and they induced lung injury, mild injury with simple surfactant depletion, a well-known model. And for the severe injury, they did the same surfactant depletion, but they used injurious mechanical ventilation for some period of time. And then they had the animals breathe spontaneously or with mechanical ventilation. They were given neuromuscular blocking agents. And the results can be summed up in this slide or 2. So on the left, you can see mild injury. This is the pathology. You can see some injury. And interesting, with the mild injury, on the left is no spontaneous breathing. On the right is plus with spontaneous breathing. And you can see that with the spontaneous breathing, actually the lungs look a little better than they do without spontaneous breathing. However, the result is dramatically different when the animals have severe lung injury. On the left at the bottom, you can see severe lung injury, a mechanically ventilated animal. You can see injury, but when the animal breathes spontaneously, you can see that the injury is much, much greater. That's the picture at the bottom right. When they quantified this, you can see the results, the lung injury scores. The top 2 are mild injury and no spontaneous breathing, and then mild injury with spontaneous breathing. And you can see the lung injury score actually improved. So spontaneous ventilation helped if you have very mild lung injury. With severe lung injury, however, spontaneous breathing, as you can see, did not help. In fact, the injury increased. So the major message here was that, yes, you can get self-inflicted lung injury, but importantly, it depends very much on the underlying disease. And that makes sense, right? We all breathe spontaneously. You see athletes breathe spontaneously at very high volumes. They don't develop ARDS after running a marathon or doing a lot of exercise because they don't have lung injury to start with. But if you start with lung injury or bad lung injury, spontaneous breathing can make things worse. Takeshi and, as well did some beautiful experiments looking at the potential impact of pendulift. And pendulift is the movement of gas within the lung due to inhomogeneities. And that can occur even though you've got a closed airway by moving from different regions of the lung. So this is taken from this. This is in a pig looking at pendulift. You can see on the left here the zones, zone 1, 2, 3. Zone 4 is the most dependent region. And then they used EIT to look at the distribution of ventilation. How does the ventilation occur during a breath? So the top two, let's see if I can't get a marker, but if you look at the top two curves, they're airway pressure, esophageal pressure, and you can see the zone 1 to zone 4. You can see, if we start with zone 4, when the breath starts, the pig starts to breathe in, and you can see that there's an increase in volume in zone 4. Look, however, in zone 1. In zone 1, when the animal is starting to breathe, there's gas that's decreasing. The volume is decreasing. So gas is flowing from the non-dependent regions to the dependent regions during this breath. This is during spontaneous breathing. When they looked at pressure control ventilation without spontaneous breathing, you see that phenomenon does not occur. So think about this. During a breath, what's happening, there's volume going from the non-dependent regions to the dependent regions of the lung. And this can have implications, and I'll show you that in a couple slides. This is a study from Morris et al. Looking at assessing whether spontaneous breathing could depend on the level of PEEP, and could the injury cause depend on the level of PEEP. And they used animal models of acute lung injury, and looked at a number of things. I'm just going to show you the EIT and the distribution of inflammation. So this is the EIT, looking at the dependent lung regions, and you can see that in this case, with spontaneous breathing, there's increased lung stretch due to pendulift. That's the flow at the bottom of the lungs, you can see at the dependent regions of the lungs. Interestingly, and they quantified this by saying, look, they made their measurements, and the tidal volume to the whole lung was only 7 ml per kilo, but the local lung stretch was equivalent to that as if the animal had 14 ml per kilo tidal volume. So you understand they're breathing spontaneously. The lower part of the lung is expanding as if it was receiving 14 ml per kilo, even though the tidal volume was 7 ml per kilo. So I think this is a very interesting way to quantify this. And then they looked at the degree of inflammation. They used PET scan, and they looked at inflammation. The yellow here represents, increased inflammation, and the red is less inflammation. And you can see that the increased inflammation was in the dependent lung regions, the same regions which were overexpanded. They then looked at the effect of PEEP. I mentioned that was one of the main goals. So you can see with low PEEP, first PET scan is at baseline after some period of ventilation, the second PET scan, and you can see that there's increased inflammation, largely in the dependent lung region. When they increased the PEEP, you can see that they removed this inflammation in the dependent lung regions. And the idea here is that you get these abnormal ventilation. You get this abnormal ventilation because there are inhomogeneities in the lung. You have a lung that's sort of consolidated. It doesn't transmit the pleural pressure the same way. So when you homogenize the lung, when you add some PEEP, this improves. So let me then summarize sort of some of the key mechanisms by which self-inflicted lung injury might occur. One, there could be increased stress and strain. With breathing spontaneously in those, if you think about those animal models, the animal model with the sheep, by increasing drive, you can get increased lung volume. That can lead to injury. There can also be asynchronies if the patient is ventilated due to double triggering, so patient ventilator asynchrony. Pendolift, I think, could be a major mechanism, and that's the redistribution of volume, as I talked about, and with increased expansion of the dependent lung regions. And I haven't talked about this, but there can be changes in lung perfusion as you have changes in decreased interalveolar pressure, decreased pleural pressure, increased venous return, changes across the lung that can lead to transudation into the alveoli and therefore injury. So what's the clinical evidence for PCLE in humans? Well, this is much more difficult, and I can only give you indirect suggestion that maybe PCLE is happening. I know that's not very satisfying, but that's the state of the art, and I think we need more studies on this. So first, there's a number of studies that have shown, if you look at patients who are treated with non-invasive ventilation, the patients who go on then to failure, who need intubation, are the ones who, during non-invasive ventilation, have higher tidal volumes. So in this study, the patients with mean tidal volumes less than 9.5 were more unlikely to require invasive mechanical ventilation. You can see the non-invasive failure was about 20%. If the tidal volume was higher, it could be 65%. Now, I know you're thinking, well, of course, that just means they may have worse lung injury, they had increased drive, and that's why they had increased tidal volume. I agree. That's a possibility. We don't know. Another similar study now from Arek and colleagues looking at P.1. The red is P.1 less than 5, so not an increased, a decreased drive. And the blue is increased drive. And you can see the patients who had increased drive were more likely to have a 90-day mortality. This is another study by Takeshi Yoshida looking now at Pendolift in patients now. This is not an animal, this is a patient, because you can use EIT in patients, and you can see the same phenomenon occurs. If you look that red line, you can see zone 4, you can see that the patient starts to breathe. Zone 4, the dependent lung region, the volume increases, and in the higher zones, the non-dependent region, zone 1, the flow decreases to those regions. So again, showing that, and this is very important, this kind of Pendolift can occur in humans, not just in animals. We also know that there's the phenomenon of negative pressure pulmonary edema. If you have patients with severe upper airway obstruction, they can generate large negative pressures and can develop pulmonary edema, which is obviously a lung injury and a form of lung injury. And so that's, I think, relatively well known. And as well, and finally, if you look at studies, a Papazian study looked at giving neuromuscular blockers for the first 24 hours, which would remove the PCLE completely because the patient is not breathing. You can see mortality was lower. You know, I know, of course, we've had the Rose study which suggests that maybe this is not the case, but again, some evidence that this might occur. So if this does occur in humans, what can we do? And Pratik actually covered this, so I'll go do it very briefly. First of all is how do you identify the patients who might suffer from this? Well, first of all, if you think of the animal studies, patients who have worse lung injury are those patients who are more likely to develop this. So severe ARDS, more likely to happen. And when I say severe, I don't necessarily mean on oxygenation. Ideally, you could look at injury based on CT scan, or maybe we don't know yet whether worse compliance could tell you this is the case as well. If patients have metabolic acidosis, severe pain, they can have an increased drive to breathe. You can assess drive, as was mentioned, their clinical signs, accessory muscles, tachypnea, and you can make some measurements. You can look at swings in esophageal pressure. If the swings in esophageal pressure are greater than about 15, could be happening. Breathing spontaneously, patients who have very, very large tidal volumes. That's often a case of situation where what do we do with this patient who's breathing spontaneously, intubated, but they're breathing with very large tidal volumes? Should we sedate and maybe paralyze them to try and improve that? Very high P.1 occlusion pressure, and potentially using electrical impedance tomography might be helpful. What can you do if you think that the patient might be suffering from PCLE? Well, you can try to treat the underlying cause of the high drive. And try to improve oxygenation if they're very hypoxemic, if they have a metabolic acidosis, address obvious things like fever, anxiety, delirium, and minimize patient ventilator dysynchrony. Breath stacking can be deleterious. In some patients, no matter what you do, because of the probably high inflammatory burden in the lung, they're going to have high drive, and be breathing very heavily no matter what you do. But you can try to do all these things. You can try the sedation and analgesia if there's pain. What's been done is there's some studies looking at partial neuromuscular blocking. Blockade. I don't think that's for prime time yet either. It was, a very nice study. If you titrate the neuroblocking agent very carefully, you can decrease the swings. You don't decrease really the central drive, but the swings in pressure, which might be beneficial, but that needs very close monitoring. And optimized ventilator settings. I showed you evidence that increasing PEEP might help to make the lung less heterogeneous, more homogeneous, less of this dependent lung region injury. So in conclusion then, I think there's very strong evidence that P. cili occurs in animals. And the important point here, I think, is that it depends very much on the underlying degree of lung injury. The more injury there was, the more likely it was that these animals developed self-induced lung injury. And in fact, if there was very mild injury, I showed you that, in fact, the spontaneous breathing could improve the lung. Trouble is, we don't know where that demarcation point, certainly in patients at the bedside, we're not going to be able to figure that out for a while. Mechanisms, increased stress and strain, just even homogeneous increase in stress and strain. But there could be pendle lift, and I think pendle lift is an important mechanism that hasn't been thought of very much, certainly at the bedside, and the impact on hemodynamics can lead to increased injury. In humans, as I said, I think it's only suggestive evidence. I actually think that this is happening. There's no reason we are dealing here with physiology, and the physiology and the biology, of course, but between the animals and the humans in this situation should be very similar. The studies on ventilator-induced lung injury in animals and humans led to common treatment that was effective in animals and in humans. And the implications, I think it's reasonable to monitor and take action to limit some of the excessive spontaneous breathing, as I mentioned, if you pick it up, if you think it's a concern. But as was mentioned, Pratik mentioned that this is not ready for prime time. I don't think we're ready to say this is what you have to do, but it is a time for us to do some clinical trials addressing this issue. So thanks very much, and be happy to take questions.
Thank you, Dr. Slutsky, for sharing your expertise. Finally, we have Dr. Xavier Monet for our last talk. Xavier Monet is a professor of intensive care at the Paris South University and works in the medical intensive unit of the Bicêtre Hospital. He's a world-renowned researcher and lecturer who needs no introduction. Today, he will talk on the challenges in weaning from mechanical ventilation. Dr. Monet?
Thank you very much for your kind introduction. Good afternoon. And indeed, I'll speak about the challenges in weaning from mechanical ventilation. And these are my conflicts of interest, especially with the Pulsion Medical System, Baxter and Massimo for this presentation. Challenges in weaning from mechanical ventilation. What's the very practical problem? Our patient is under mechanical ventilation, and on one day you start weaning the patient with a spontaneous breathing trial, whatever the way you perform this trial. But this SBT fails. Of course, as you all know, this may be due either to lung problems, I mean incomplete lung recovery, to problem with the muscles, inability to breathe, but also to cardiac dysfunction. And that's the point on which I would like to insist. From challenges in weaning from mechanical ventilation to cardiac challenges in weaning from mechanical ventilation, and I will try to show you how important this is and how to deal with it in practice. The first problem is indeed, how is it important? I mean, is it a very common issue? If you read some very nice position articles here in a review, it was said that this condition of weaning-induced cardiac dysfunction has become more recognizable, but that its true incidence is unknown, and this was, as you see, published in 2019. And one must say, indeed, that the studies that investigated the incidence or even the prevalence of this winning-induced cardiac dysfunction were quite small-sized and reported an incidence from 40 to 90%. Again, these were small-sized studies and especially included very specific patients. That's why we conducted this multi-center study, including 500 patients who performed more than 600 spontaneous breathing trials in different centers with very different conditions for the patients. And to summarize the results quite rapidly, you'd see that 44% of them failed the weaning trial, and we were able to establish, to diagnose winning-induced pulmonary edema, WIPO, in not less than 36% of the patients. In 36% of these patients, weaning failure could be attributed to this pulmonary edema induced by mechanical ventilation. Then I will ask myself and show you the answer for 3 questions. What are the basic mechanisms which are very important to understand to know how to treat these patients? How could we detect spontaneous breathing trial inducing winning-induced pulmonary edema, and how do we treat or may we treat these patients? The mechanisms, as you may know, are all related to heart-lung interactions. In fact, when you disconnect the patient from the ventilator, or when you reduce the degree of lung assistance, for instance, with pressure support and ZEEP or low levels of PEEP, in fact, you may deteriorate the 3 components of the cardiac function, of the LV function, the LV preload, the LV afterload, and sometimes the LV contractility. And basically, this is due to 3 triggering mechanisms. First, when the patient is moved from positive to negative pressure ventilation, you decrease the intrathoracic pressure, and especially in case of respiratory distress, there are some large swings in these negative pressure swings in the thorax. And this promotes venous return, this increases cardiac preload, which of course may induce some pulmonary edema. But the decrease in intrathoracic pressure is also transmitted to the left ventricle. It's like if you attracted on the free wall of the left ventricle, impeding the LV ejection, which means increasing the LV afterload. And the adrenergic stress, especially produced by the psychologic stress, but also by hypercapnia, the hypertension that it induces may even further increase this left ventricular afterload. These patients, especially in case of respiratory distress, breathe at a very high pulmonary volume. And this stretches the pulmonary circulation, increases the right ventricular afterload, and sometimes even induces a right ventricular dilation, which by decreasing the LV compliance contribute to this winning-induced cardiac dysfunction. Finally, in some patients, myocardial ischemia may result from this deterioration of the loading conditions of the heart and to a decrease in the oxygen supply, which may lead to myocardial ischemia leading to LV dysfunction, LV contractile dysfunction. So you see that all these pathways may act in case of spontaneous breathing, finally leading to winning-induced cardiac dysfunction. The question how to detect is quite important, because indeed, if you detect that this spontaneous breathing trial fails due to winning-induced pulmonary edema, you may treat the patient in order to fasten extubation and shorten the duration of mechanical ventilation. Facing this failing spontaneous breathing trial, you may suspect winning-induced pulmonary edema. Of course, if obvious causes of winning failure have been discarded, for instance, if lung improvement is very likely, if there is no obvious muscular weakness, but also if risk factors of winning-induced pulmonary edema are present, and that's quite important. Indeed, In the study I showed just before, we observed that the two factors independently associated with the occurrence of winning-induced pulmonary edema were previous cardiopathy and COPD. And you can easily understand that from the pathophysiological pathway I detailed before. Patients with COPD have very large negative swings in intrathoracic pressure because of the bronchial obstruction. They breathe at a very low intrathoracic pressure level and, by the way, at a very high lung volume. And this respiratory distress even enhances the mechanism of the increased venous return I said before. And second, the failing left ventricle is particularly sensitive to any increase in its afterload. And so you understand how these two conditions may promote winning-induced pulmonary edema, which is quite unlikely in a patient who has been ventilated for only 2 days, for instance, for drug intoxication, but much more likely for a patient with previous COPD and a previous failing left ventricle. In that study, we showed that winning-induced pulmonary edema was responsible for 70% of respiratory SPT failures in COPD patients and in 50% of the failures in previous cardiopathy patients, meaning that not only this is not an uncommon condition, but even more this happens in some patients, and the risk factors are quite clear. Then, of course, to establish the diagnosis of SPT, you must have something that detects what happened during the spontaneous breathing trial. I mean something that has changed from baseline and that indicated winning-induced pulmonary edema. And today, 6 ways to diagnose this winning-induced pulmonary edema could be used. The reference is still the pulmonary artery catheter. And by the way, in the first study that has described that, by François Lemaire, Warren Zappel, and Jean-Louis Teboul, they used the pulmonary artery occlusion pressure and the pulmonary artery catheter to first evidence this phenomenon of winning-induced pulmonary dysfunction, pulmonary edema. And you easily understand that the measurement of PAOP, pulmonary artery occlusion pressure, is likely the most sensitive and most specific way to evidence the loading condition changes induced by the weaning from mechanical ventilation. However, we have 2 problems. The first is that this pressure, the PAOP, is quite difficult to measure in spontaneous breathing patients and especially in case of respiratory failure. And also the invasiveness of this device, of the pulmonary artery catheter, is today less acceptable in patients just on the day when they will be extubated. That's why echo might be interesting, because you know that cardiac echo may in fact estimate PAOP by analyzing especially the mitral flow and the motion of the mitral annulus, this E/E prime ratio. Nevertheless, it's likely not the ideal way of diagnosing WIPO. First, because, again, it's difficult to perform echo in a patient sitting in his bed or in her bed with respiratory distress, but even more because and it may be linked to the previous fact, the diagnostic ability is quite poor. It's been tested, by the way, in not that many studies. In that study with Bushra Lamea, Jean-Louis Teboul, and others, we showed that indeed the E/A ratio was not able to diagnose winning-induced pulmonary edema, and the E/E prime ratio performed better, but not ideally, perhaps again because it's difficult to perform precise echo measurements in these conditions. Of course, a much easier way would be to use another common way we use to diagnose cardiogenic pulmonary edema, the BNP level, or even more, the BNP level changes. I mean, increases in BNP compared to baseline. 2 studies in the literature indeed confirmed that if BNP increases either in absolute value or in percent changes, you can diagnose winning-induced pulmonary edema quite easily. The problem may be the price, especially because another way of performing the diagnostic the diagnosis with biology, to perform the biological diagnosis, may be to use hemoconcentration. What do I mean? All patients experiencing cardiogenic pulmonary edema experience hemoconcentration. I mean that the transfer of plasma to the interstitial space and to the alveoli induces significant hemoconcentration. And all studies by Max Harry-Weil have demonstrated that a quite large volume of plasma is transferred to the interstitium and the alveoli in case of hydrostatic pulmonary edema. And this volume is so significant that it induces hemoconcentration that you may detect with plasma protein concentration or hematocrit. In this study we performed years ago with the team of Jean-Louis Teboul, we could see that indeed this increase in plasma protein concentration, so measured before the weaning trial and just when the patient fails the weaning trial, could differentiate patient with and without weaning-induced pulmonary edema with a very good specificity and a good sensitivity. And indeed, if you look at a very common clinical case, if you see, for instance, that the plasma protein concentration increases from 58 to 75 just when you wean the patient performs the spontaneous breathing trial, what else than something like this could explain this respiratory failure? This obviously indicates hemoconcentration and likely weaning-induced pulmonary edema. Another way to diagnose pulmonary edema is, of course, to directly show the increase in lung water. And you can measure lung water with transpulmonary thermodilation, as you may know. And we showed in this study that indeed you can detect the increase in lung water just by transpulmonary thermodilation, diagnosing weaning-induced pulmonary edema quite directly. But of course, the patients, you do not need to insert such an invasive device just for the purpose of diagnosing weaning-induced pulmonary edema. Is just to say that if a PICO, if a 1000 device, if an EV1000 device are still present on the day of the spontaneous breathing trial, do not miss measuring lung water, because the changes, the increase in lung water may help you performing the diagnosis. Finally, another way to directly evidence lung edema is to use lung ultrasounds and to detect these B lines that indicate interstitial lung edema. And in this study, we showed that the increase in B lines from the beginning to the end of the spontaneous breathing trial could detect weaning-induced pulmonary edema if the number of B lines increased by more than 6. The sensitivity and the specificity of the diagnosis were quite good. I must say it's a bit cumbersome because you must measure the number of B lines before, after, in 4 quarters, in 4 quadrants of the thorax. It may take time, but this is, of course, completely non-invasive. Once diagnosed, the question is how to treat the patient and, more precisely, what to do before the spontaneous breathing trial and the one of tomorrow that may avoid an occurrence of weaning-induced pulmonary edema again and may help wean the patient earlier. Something that will allow the success of the next spontaneous breathing trial. Angioplasty is often cited, but it should, of course, be decided if an obvious myocardial ischemia occurs during the spontaneous breathing trial, but it's quite uncommon. In this study, for instance, by another French team, you see that that spontaneous breathing trial induced myocardial ischemia in a very small proportion of the cases. So myocardial ischemia is likely an uncommon cause of this weaning-induced pulmonary edema. Giving an inotrope may be a solution. Nevertheless, it's not logical because it may increase contractility even if the LV contractility is normal. And again, if there is no myocardial ischemia, the problem is not a decrease in cardiac contractility, but more a problem of the changes, of the deterioration of the LV loading conditions, as I told you at the beginning. Changing the loading conditions, this may be possible with nitrates, which indeed avoid, of course, decrease the cardiac preload, but also may avoid hypertension that I showed you aggravates winning-induced pulmonary edema. And so you may start it just on the day of the second spontaneous breathing trial and adapt the dose in order to avoid hypertension. And in the same line, avoiding hypertension typically by starting anti-hypertensive drugs on the day before the spontaneous breathing trial in hypertensive patients may be, of course, an obvious solution. Finally, the easiest way, and at least the most common used way, to avoid the recurrence of this winning-induced pulmonary edema is to remove fluids. But here the question is always the same. How much fluid should I remove for preparing the second spontaneous breathing trial of tomorrow? Should I remove 1, 2, 3 liters? And in which patients should I do that? Is it safe to do so? This is the question we attempted to answer in this study, where we assessed preload responsiveness for the passive leg raising test before the second spontaneous breathing trial in patients who had failed the first one. And the idea was this one. If the patient is preload responsive, which again is a normal condition, then they may be able to cope with the changes in the loading conditions I showed you at the beginning. I mean, a patient with a normal preload responsive condition may be protected against winning-induced pulmonary edema. And so before, again, the spontaneous breathing trial, we performed passive leg raising, looking for preload responsiveness and unresponsiveness. And we showed indeed that patients in whom winning-induced pulmonary edema occurred again were more preload responsive than the other ones. Preload unresponsiveness was favoring the recurrence of winning-induced pulmonary edema, indicating again that these patients were unable to cope with the changes in the LV loading conditions. The goal is not to diagnose the winning-induced pulmonary edema, but more to prepare it, to decide in which patients to remove fluids, and perhaps in which how much fluid to remove in these patients. You may remove fluids until the passive leg raising becomes positive again, until the patient becomes preload responsive again. It's not been tested by a study, but in the study I showed just before, you see that the patients who had a negative passive leg raising at the beginning and experienced winning edema, some of them received diuretics and still remained unresponsive to the passive leg raising test, and in a majority of these patients, winning-induced pulmonary edema appeared again. On the contrary, in the patients who received diuretics, where it made the patient responsive, or fluid removal was enough for making the patient responsive to preload changes, winning-induced pulmonary edema appeared only in a minority of cases again, suggesting again that one solution, but again not tested prospectively, would be to remove fluid until the patient becomes preload responsive. At least it shows that preload unresponsiveness is a condition that favors winning-induced pulmonary edema.
Time is finished.
So to conclude, I showed you that it's a quite common condition, that the mechanisms are quite complex, but all due to heart-lung interactions, that today we have ways to diagnose it at the bedside. Some are reliable, non-invasive or minimally invasive. And finally, if the treatment is not well defined, it may try to restore the loading conditions of the left ventricle. Thank you very much for your attention.
Thank you very much for this interesting talk. I think because we run out of the time, I think we have maybe because it's very provocative, interesting talk. Maybe we could allow for 1 or 2 questions. If there's nobody, I think I have 1 comment or question I could just elaborating about to Dr. Patrick about spontaneous. I think the message, I don't know, it goes to the practitioner to avoid spontaneous, or instead of calling it probably excessive spontaneous, patient effort during weaning or during mechanical ventilation. What do you think about this?
Yeah, I think it's a really good question. The baseline would be to say that at the moment there just isn't sufficient data to give any strong recommendations about what to do. But in the context of assessing a patient and establishing that there is spontaneous ventilation and it is leading to elevated transpulmonary pressure, I think it's reasonable to think about how you can mitigate that. Now, the challenges of it are that quite frequently the patients where we think this is most problematic in are the ones that are probably already maxed out in terms of the drive pressure. So what are our realistic options? And then you have to start thinking about, the things we talked about, sedation, neuromuscular blockade, and or do we need to think about other ways to try and mitigate the respiratory drive? And, can we use ECMO, for example, to try and match what the respiratory demands are for those patients? I think an important message here would be that in the context of us as healthcare providers delivering sufficient prescription of mechanical ventilation, there aren't that many options that will allow us to help the patient liberate from the ventilator under those conditions. And in that context, if you're not meeting the respiratory demands, it's a serious problem. And that's really where we're at with the field, is that we need to start assessing whether or not spontaneous breathing is happening in this context.
Any other question? One more question? Maybe. We thank all our distinguished speaker for their talk, and please go for a break and come back after a few minutes at 3:30 for the next session. Thank you.